First of all, thank you so much for the kind invitation. I'm relatively new to this field, so I really appreciate the opportunity to learn from all of you. Today, I'm going to present the preliminary baseline results of a cohort study called COVID-UPP, and I'm going to share some of our lessons learned from recovery classification. I do not have any conflicts of interest. I do need to thank the CDC for their funding and support, and I need to thank Nancy Klimas for inviting me to co-lead this study. So first of all, why doing COVID-UPP? So really was the fruit of all the lessons learned from ME. We knew that ME had been a disease neglected and underfunded for years, and that we needed to produce data as fast as possible, describe and try to create awareness. And there were some things that we knew from the get-go that we wanted covered, and it's similar to what Eva presented about Discover ME. So we knew, given that this is a heterogeneous condition with relapsing remitting characteristics, we knew that we needed to do a longitudinal study that was long enough and that we needed to have frequent follow-ups. We also knew that we needed to have a standardized instruments that we could use to compare to ME prior studies, to ME cohorts, and also help us determine if people with long COVID were developing the ME phenotype of the disease, and that we needed a phenotype arm or a subset of patients having much more in-depth characterization. And there were a couple of other things that we wanted. We wanted to include minorities. That is a weakness that we've had over the years, and given that we're in Florida, we wanted to have a representative sample that included Hispanics. And we were curious about how our longitudinal arm is through a REDCap platform, basically email, online surveying. We were very curious about how good screening through that mechanism would help us discriminate groups. So the design of a study was presented by Nancy last year, but in a nutshell, it's a multi-site prospective longitudinal cohort that started we started recruiting in January 22, and is ongoing. The recruitment ended, but the follow-ups are ongoing. We wanted to make this really as community-based as possible, to recruit not from clinics, but from the community. So what we did is very massive outreach of patients through listservs from the major health systems in Florida, but not to anyone that the health system had touched. So we deployed almost 200,000 emails, and we recruited 1,000. We didn't reach the sample with some referrals from clinics, so that we made sure that we also had the more severe patients. And our target was to have 55% Hispanics, and this is quarterly follow-up up to 36 months. And there are the validated instruments that we are using, similar to those previously used in MCAN and other ME research. For our screening process was a two-step process. We had the first was a global question: do you feel that you have recovered from COVID-19? And this is a question that has been used in several of the large-scale national surveys, like the CDC Pulse survey. So we wanted to use a question that has been used for screening purposes, and we use in sequence the CDC symptom inventory that addresses most of the domains that are very frequent in ME and in long COVID. And in fact, to be classified, we wanted to include in this study people that are recovered after a COVID infection and people that were unrecovered. So we use the CDC-SI to classify them. So in order to be classified as unrecovered, you needed to have fatigue plus one more symptom and reach a threshold of severity and frequency. And we wanted to concentrate more in the fatigue dominant. It was the most frequent reported symptom, and we wanted more interested in the fatigue dominant presentation. And to be recovered, people needed to not have any of these, no fatigue or any other symptom after COVID. And we had envisioned having a not eligible group, and the not eligible group was people that didn't meet the criteria. But what we started seeing is that a lot of the participants had many, many symptoms, post-COVID symptoms, that did not reach the threshold, but there were many symptoms. So we decided to keep this group, not to say they're not eligible, we're not going to follow them, but rather keep them as a third group, because this group may be either on their way to get better, on their way to get worse. So we kept it. We're still struggling to name them. So for now, we're calling them the boundary group. It could be an indeterminate group. And the other thing that we noticed is that these two instruments, the single question and the CDCSI, had a significant discordance, and we'll talk to that a little bit. So first, to describe our cohort, we recruited 1,006 individuals with a CDC screener. We classify them 639 as unrecovered, 193 as this boundary group, and 174 recovered. When we looked at their demographics, the headline really is that unrecovered group patients were more likely, and the boundary group for that matter too, more likely to have been hospitalized for their COVID infection. They were having more comorbidities, and they had significantly more financial hardship. And we use a validated question by the National Academy of Medicine to measure financial hardship, and it was very significant. The other thing that we noticed is that Hispanics, we had the 55 target that we wanted, but in the recovered group, they were a little bit overrepresented. You can see that here, 64%. And then obviously, the main question is this method of classifying people really picking up distinct groups? And you can see here that it is. This is the PROMIS domain, and you can see across the PROMIS domains, we see that the unrecovered are really worse off compared to the recovered in green. So they have worse physical function and worse social participation, more fatigue, more sleep disturbance. They are all abnormal compared to the recovered that are even better than the population norm, which is this line over here. And then when you look at the boundary group is always a square in the middle, always in the middle. So what you can see with this is that these three groups are kind of like a continuum. There is like a dose effect. The recovered are better, then is the boundary, then is the unrecovered. And when we did the same exercises with other instruments, like the poll and other instruments, we saw the same pattern. Here I'm sharing with you the one that is the sharpest differentiator, PEM. So when you see PEM was the one domain that had the largest difference between the unrecovered and even boundary unrecovered. And so PEM came as with ME as a really potent predictor of the condition. But let's get back to the discordance I was telling you about. We had noticed that the single question and the CDCSI not always correlated. And here I'm showing you a cross-tabulation of the CDC criteria that classify people as unrecovered and recovered, and how people answer to the single question. When you look at the people that were classified as recovered, most of them were concordant, 90% were concordant, and just a few reported being unrecovered or being unsure. But when we see the unrecovered group by CDC criteria, 30% had reported being recovered, and 25% reported being unsure. So in total, almost 55% would have been missed if we only used the single question as a way to determine if they had a post-COVID condition of any kind. And so that is very worrisome for public health policies, for clinical purposes, for research purposes, because we are missing people in all these surveys that are only relying on one question. We wanted to look more carefully, and we did some of the other, the figures like I show you for the PROMIS, and we saw a dose effect within the unrecovered, but this is the graph that was most helpful understanding what is going on with this discordance problem. So here, what we plotted is the most kind of like the separators. So in this axis, we have post-exertional malaise, And in this axis, we have physical function. The higher, the better, and in this case, the higher, the worse. So you can see here in green that people that are recovered and concordant had very good physical function and very low post-exertional malaise. In contrast, the people that were concordant and recovered over here have very poor physical function and a lot of PEM. But look at group 1. This is the group that had similar symptom burden, so they were unrecovered, but they reported themselves as recovered. They have almost identical physical function as the recovered group. They have a little more PEM, but their physical function, it probably made them think that they had been recovered. They are in a kind of a compensation zone. Group 3 is the group that had symptom burden, that they met criteria for being unrecovered, but they were unsure if they have something. This is kind of was very squarely in the middle, had, a little more PEM and a little less physical function. And our preliminary analysis of these shows that sleep disturbance seemed to be modifying something. We will report back to you next year, but it seems that sleep disturbance may be part of this story, but a lot of more research to happen. But we did a lot of modeling, and I'm going to share with you just these, our simple model. What predicts this discordance between what the CDC screener picks up and what people report? And this was very surprising. The one with the strongest prediction was, it doubled the odds of being discordant was financial strain. So the more financial strain, the more likely people were to report that they were recovered when they were classified as unrecovered by the CDC. Other predictors of the discordance were psychiatric comorbidity, having higher fatigue, particularly in the context of better physical function. But then what protected, what made sure that you reported correctly or that you were concordant, if you will? It was PEM. So if the more, the higher the PEM, the more likely that you are to be reporting both instruments that you are ill, and prior hospitalization. So this is starting to take shape and produce more questions than answers, really, because obviously PEM is an illness anchor, is the key to recognition. Fatigue alone, we saw that it was kind of, when associated with good physical function, it seemed to be confused by these patients that are newly feeling these symptoms. But PEM is really unambiguous. And we had seen that this is an important symptom from ME. So, and we are seeing that there is a group of people that seem to have low PEM, but what I want to, and I've heard this from other investigators saying that in long COVID there is less PEM. I want to warn us about that. I want to say PEM, as any other symptom, can be fluctuating. Our PEM instruments are, as we've been hearing all day, are not the best. We need to improve how we picked up PEM, and so we better not dismiss people because they don't have PEM, because these are people that do have a lot of symptoms. So we need to be careful, and we need longitudinal data. We need better PEM instruments, and when we get to this data, we need to kind of differentiate these two competing hypotheses. Either this group is kind of like in a relapse and remitting or in an early stage and they're on the way of developing PEM, or is a distinct phenotype that doesn't have as much PEM and have other things. So, and the other thing that I want to leave you with is this issue, this story of the financial strain. I'm really happy that Nancy, I worked in health disparities before transitioning to this, and Nancy, embraced my idea of measuring social determinants of health. And here we are seeing that this line of questioning, just with a single question, may be making the inequity of an already inequitable disease even worse, because now we are undercounting particularly the people that are probably with the least amount of resources, the people with more financial strain. And obviously the other lesson is, if you get people with financial strain, if you saw that predicts people not reporting them as ill, that we probably need to dig a little deeper. We need to ask more questions. And the reason why this happened may be because they have 2 or 3 jobs. At least in the US, there is people that have 2 or 3 jobs, and they may be confusing. I'm tired because I'm working too much. Or there may be other factors. They cannot afford to be sick, or they don't have access to the doctors and nobody's told them that there is something wrong with them. But the reality is that this is happening, and we need to do much more studies on that. So in conclusion, our study is ongoing, and we have finished recruitment. We will have results of the longitudinal part next year, but so far we can report to you that these discordance, that using just a single question for screening seems to be insufficient, that using screeners that do not capture PEM may be insufficient, and we need to really follow these different phenotypes that are emerging from all the cohorts that we're doing and trying to clarify the story of long COVID. And I appreciate you. Thank you so much, everyone, for this and for having me. Thank you.